All right, so good morning, everybody. Thanks for joining us. My name is Dr. Laura Certain. I've interacted with some of you over email and phone about various patients. I'm an infectious disease doctor at the University of Utah. I'm also section chief of infectious disease at the Salt Lake VA. And my area of interest is in orthopedic infections. So I work pretty closely with the orthopedists here at the University of Utah. I have clinic with them a couple days a week. And so I'm going to talk to you today about bone and joint infections. I was particularly asked to speak about diabetic foot infections. And so that'll be the middle part of the talk, so to speak. But I'm happy to answer questions along the way or at the end about really anything ortho ID related. And I call it persistent conundrums in bone and joint infections because these are the questions, right, that you ask an ID doctor. Who needs antibiotics, which ones, and for how long? And these are particularly challenging questions in orthopedic ID because, to be perfectly honest, we don't know. We do not have great randomized trials about how long to treat orthopedic infections. There are some, and I'll go over those. And also, it's really often hard to know how long or when somebody is cured, as I'll talk about. So these infections are kind of notorious for coming back even after you think you've done a good job of treating them. And we'll go over some of that today. So here's a brief roadmap. I'm going to talk a little bit about the pathophysiology of bone infection, some of the basic science behind this. Then we'll talk about the management of diabetic foot infections, and then talk a little bit more about antibiotics for osteomyelitis, sort of which ones and how long. So, and I put these are my two little mini-me's. So it's my, PhD hat and my MD hat, both of which have played into this talk today. So just to begin, to make sure we're all on the same page, osteomyelitis is an infection of the bone and bone marrow, and it can occur basically through three routes. So there's the hematogenous route, where it starts off in the bloodstream, finds its way to the bone, and then sets up shop. Or it can spread from an infectious a soft tissue infection that's adjacent to the bone, and then it spreads to the bone. That's basically what's happening in diabetic foot infections or patients with vascular disease. Or it can happen due to surgery or trauma. So the bacteria can find their way to the bone at the time of trauma or of surgery. And by far, or not by far, but one of the most common causes of osteomyelitis is Staph aureus. And so most of the research out there actually has been done on staph, not on other bacteria or fungi. So it is, again, worth remembering that most of what we know or think we know about osteomyelitis and bone and joint infections is really about staphylococcal osteomyelitis and bone and joint infections, and how much that applies to other bacteria is a little bit debatable. This is sort of my world. These are the most common types of bone and joint infections in adults, and this is what I see on a weekly basis. So starting from the upper left, we've got prosthetic joint infections, and then vertebral osteomyelitis, not shown here, but also spinal implant infections, diabetic foot infections, and infections of hardware planted to treat trauma and other fracture fixation devices. All right, so let's talk a little bit about the pathophysiology of bone and joint infections. So as any orthopedists on the call probably know better than I do, bone remodeling is a balance between osteoblasts, which build up the bone, and osteoclasts, which break down the bone. And this sort of remodeling, bone is continually remodeling, and it allows it to respond to various stresses. But what happens when staph find its way to the bone? So Staph aureus has bacteria that allow it to attach to the bony matrix. So staph has surface proteins and other polysaccharides that allow it to attach to collagen and fibronectin. And then from there, it can form a biofilm. So this is one thing to note, like we often think about biofilm in the context of orthopedic devices, but it can also form just on the bone itself. So you don't necessarily need implanted hardware to have a biofilm infection. So the staph bacteria attach to the bone, they form a little microcolony, and they then produce this sort of gooey polysaccharide matrix around them, which is the biofilm, and it protects them both from the immune system and from antibiotics. And just to go over that again, the biofilm is a community of bacteria embedded in a sticky layer of polysaccharides. So dental plaque is an example. The lungs of people with cystic fibrosis have biofilm in them. And it can form on any implanted medical device or just on the bone itself, as I said, but it's very difficult to eradicate because the bacteria inside the biofilm are protected from the immune system and from antibiotics. Staph may also invade the canaliculi. So this is a more recent finding, and it was actually a finding in a diabetic foot infection. So this is a scanning electron micrograph of a bone. So the OC is an osteocyte. And basically what they found is that the staph bacteria kind of can invade those canaliculi where the tendrils of the osteocytes are spreading out, and they can spread up the bone that way. They can live inside osteoblasts themselves, so they can survive intracellularly. And then they can also cause death of the osteoblasts themselves. So they can either induce necrosis from toxins or induce apoptosis. And that leads to an increase in osteoclast activity and thus bone destruction, which is why on a macroscopic scale, what you get is an abscess, right? So the infection causes the bone to basically die and disintegrate, and you get an abscess in the bone called a sequestrum, and then not labeled in the slide is sort of a wall of new bone that forms around it called the involucrum. And then with time, it can sort of form a sinus tract that finds its way out to the surface. And because these bony abscesses are often walled off, and also because mostly it's just a bunch of dead bone that's not going to come back, the typical treatment is surgery and antibiotics, or as I like to tell my fellows, that the best antibiotic is cold hard steel. Like, it is far better in general for most of these infections. You are going to need to physically remove as much of the infection as possible and then use antibiotics for doing some cleanup afterwards. And what that looks like clinically. So this is a case I saw a few years ago. This was a generally healthy 20-year-old man who was admitted with fevers and leg pain, and he had MRSA bacteremia. And I'm showing his MRI on the screen. Hopefully you can see that his left leg has a profoundly abnormal MRI. He basically had infection throughout his femur. So in late December is when he was diagnosed. He had the bacteremia and the left femur osteomyelitis, which was debrided. He got daptomycin and Clinda. He was originally on vancomycin, but young healthy people often have a hard time. We have a hard time getting adequate vancomycin levels in them because they metabolize it so quickly. And so he was treated with daptomycin and Clinda. In March, he had a repeat debridement due to persistent abscesses on imaging. He was continued on clindamycin alone. After about 4.5 months, we stopped his antibiotics. But the question comes up, though, is he cured? So he was doing okay. He still had some pain, but seemed to be doing well. And we have no idea. He has done fine since that time, so great, but there's no imaging test, there's no blood test, there's nothing you can do on exam to really say that every last bacteria is gone from inside his leg. We sometimes use ESR and CRP, and we like to see those fall with treatment, but it's worth noting in this case, for example, his ESR was still mildly elevated at the time we stopped treatment, and it continued to fall after we stopped treatment. So that was reassuring, but it's not proof, because osteomyelitis, in particular staph osteomyelitis, can recur decades later. So you can find all these case reports in the literature of osteomyelitis that has been dormant for decades, only to come back later. Now, most of these were initially treated in the pre-antibiotic era. So most of these were patients that had osteomyelitis as a child or young adult, were treated with surgical debridement, but not amputation, and then seemed to do fine for decades, only to have it recur much later on. The longest one I found was in 80 years after infection, having it come back again. So what this means is that, it's really hard to say for sure that an infection is completely gone. So I often tell my patients that they're in remission and to come back when and if their infection comes back. So going a little bit more into how and why are these infections so difficult to eradicate? It's actually the idea of persistence of osteomyelitis actually goes back to the 1940s. Joseph Bigger was doing some lab experiments with Staph aureus, and he noticed that when he treated a culture, a culture flask full of staph with penicillin, a small fraction would survive killing by penicillin, even though they weren't resistant. They didn't have penicillin resistance. And so he thought that they seemed to be in a dormant state. So basically, when bacteria were not actively dividing, they were not susceptible to penicillin killing. And he connected that, what he was seeing in the petri dish, to the fact that osteomyelitis was difficult to cure. And so he thought, well, maybe it's because some bacteria are in the sort of quiescent or dormant state, and that's what makes it difficult to cure. And since then, lots of other research has shown that there are all sorts of environments and stresses that can make bacteria enter a state that makes them more resistant to killing by antibiotics. Biofilm is one of them because they're physically protected from antibiotics and from the immune system, but also bacteria and biofilm are more likely to be dormant, not actively dividing, and therefore more tolerant to antibiotics. So that's one reason why these infections can persist, or thought to be. Staph can also form walled off abscesses. So this is actually a picture of a mouse tibia that's been experimentally infected with staph, and you can see these sort of walled off staphylococcal abscesses that are difficult to eradicate with antibiotics alone. Staph, as we know, forms biofilm both on the bone and on hardware. And it can survive within the bone structure and within the bone cells themselves. So all of those, we don't know which of those or if all of them are playing the biggest role in terms of persistence of these infections. I suspect that it's a combination, but that's some of the reasoning behind why these infections are so difficult to treat. So I'm gonna pause there, and then I'm gonna go on to talk about diabetic foot infections unless there are any questions. Okay. So again, when you all reached out to me, the request was to talk a little bit more about diabetic foot infections, which are indeed quite challenging to treat. I will point out there are guidelines from the Infectious Disease Society of America. They're getting kind of old now, but they do exist. And what I will be presenting is sort of in line with those. I will also like to highlight at the beginning that antibiotics are definitely not the most important piece of the puzzle for these patients. So when I think about patients with chronic wounds and chronic sort of persistent concern for infections in somebody with vascular disease, diabetes, smoking, maybe poor health otherwise, all these things that went into developing the wound in the first place are going to play more of a role in how that patient does than the antibiotics. I often think of it as a balance. That's why I put the scale here, and that antibiotics can sometimes tip the scale a little bit towards better healing for these infections, but they're not the most important thing by any means. The other thing I'll highlight is that multidisciplinary care is key. So what I will be presenting to you about diabetic foot infections is actually the process we use at the Salt Lake VA, where we have a number of patients with diabetic foot infections. And we actually meet fairly regularly as a team. So infectious disease, podiatry, because that's who manages these infections at the Salt Lake VA, wound care, endocrine, internal medicine. We all have a meeting to talk about the patients we have that are at highest risk for losing their foot due to a diabetic foot infection. All right, so let's go through some cases. So let's say this is a 55-year-old man with diabetes who comes into urgent care, and he has chronic ulcer on the side of his foot, and today the surrounding tissue looks a little red. So to begin with, we often have to think about these infections in sort of mild, moderate, or severe. And this is a way to think about sort of how worried you need to be and how quickly you need to get the patient care. So this patient that I just presented would be considered a mild diabetic foot infection. So, which is basically there's local swelling and local erythema, but it doesn't extend that far. But they are otherwise well. And that's one classification scheme. There are various published classification schemes, but they have not been compared. There's no consensus really on how to classify these. Um, I am How we classify them and how I'm presenting it today basically mimics more or less the IDSA severity staging, which again, it's worth noting, it does not predict the microbiology. Like it doesn't predict who's more likely to have, a resistant infection or who's more likely to have MRSA, but it does predict who is most likely to go on to need hospitalization or amputation. And so it's useful in thinking about how worried you need to be about the patient in front of you. And so basically, because those with mild infections have a very low risk of hospitalization or amputation. Whereas when you go up to people with moderate or severe infections, the risk of hospitalization and amputation is quite high. And so for mild infections, really, it's mostly just staph and strep. It's nothing exotic. And we typically would just treat as you would any other cellulitis with Caplex for a week. If there's a lot of purulence or they have a known history of MRSA in that wound, so not necessarily MRSA anywhere, but MRSA in that wound, then it's reasonable to include coverage for MRSA. Okay, but let's move on to maybe a more complicated case, or one where there's a little bit more of a decision to be made. So let's have another patient come in who also has a chronic foot, but the chronic foot wound. But today the surrounding tissue looks red and there's an area of fluctuance. So it's basically, it doesn't look mild anymore. It looks a little more concerning. So this would be classified as a moderate diabetic foot infection. So basically all the things that go along with a mild infection, plus the erythema is basically bigger. So more of the foot soft tissue appears to be involved, or there's concern for a deeper infection, whether that's osteomyelitis, septic arthritis, or abscesses. And so I see a question about the superficial wound infections. I think you mean wound cultures, perhaps? Yes. So the superficial wound cultures in general are not that helpful, especially if you're worried about a deeper infection, because the surface culture does not always correspond to what's going on deeper in the tissue. That said, if a patient grows Staph aureus from their superficial culture or from the purulent drainage of a wound, that is helpful. I mean, that typically does mean that Staph aureus is the pathogen. So I sort of think of them as helping me know if MRSA is there, then it can be helpful. Other than that, they do not correlate that well with what's causing a deeper infection. And certainly for mild infections, probably not worth it. For moderate to severe infections, the goal would be to get a deep tissue culture, so like a post-debridement tissue culture, and use that to guide your therapy. But superficial wound swabs, unless they grow Staph aureus, I am never sure quite what to make of them. All right, the other question that often comes up is like, who needs admitted? Sort of like, how quickly does this patient need to be cared for? Because often these wounds are present for months, but today they look worse. And so the question then becomes, well, it's a chronic issue, but do they need to be admitted? I think that once somebody's up to the moderate, certainly up to the severe, but these moderate diabetic foot infections are often where the judgment call comes in. I think, most of these patients, if there's concern for an abscess, concern for septic arthritis, I would say yes, mainly because you want them to get imaging probably, which can be helpful. And also in an ideal world, in a stable patient, you would get, as I said, deep tissue cultures. So not a superficial wound swab, but deeper tissue cultures before starting antibiotics. And you probably don't want to sit on these for weeks. And so depending on how your clinics and hospitals are set up, usually this cannot happen fast enough outpatient. Then the other question comes up, sort of which antibiotics to start. So talking a little bit about the microbiology, the microbiology is influenced by sort of, did they have antibiotics recently? How long they've been with this wound? What has been sort of colonizing that wound previously? So that's, I guess, where a superficial swab might be helpful. And then any recent environmental or healthcare exposure. So basically, if they have not been on antibiotics recently, if it's, not that chronic a wound, chances are that it's going to be just strep and staph. The things that influence the development of sort of more difficult to treat pathogens is the chronicity of the ulcer and how many times they've been on antibiotics previously. So again, for these moderate diabetic foot infections, it's still mostly staph and strep, but you might have some gram negatives in there. When we admit these patients, we typically put them on cefazolin because it treats the staph and strep and most gram-negative rods, especially in somebody who has not had a lot of antibiotics or healthcare exposure previously. If there's purulence or a history of MRSA from that area, then we do cefazolin plus vancomycin. And again, when I'm saying we, I mean we, the diabetic foot team at the Salt Lake VA. And if they have had a lot of prior antibiotics, then we worry more about resistant gram negatives. And so we typically put them on Unison or perhaps Zosyn plus vancomycin. There's a question about soaking exposure. That's when some patients, as part of their wound care, have been told to soak their feet. So, or somebody who enjoys taking baths, so basically if they've been soaking the wound in water, in tap water, then that is a concern for acquiring Pseudomonas. So this is just a summary of what I said. So moderate infections are typically treated with cefazolin or Unison with vancomycin added. Obviously, for these infections, if it's just a skin and soft tissue infection, oral antibiotics are also fine. And we'll talk more about the oral versus IV antibiotics later on in this hour. All right, so then this patient, so poorly controlled diabetes, fever, painful foot, hypotension, fever, tachycardia. So I'm trying to make this not subtle. So this is a severe diabetic foot infection. So it's a diabetic foot infection plus systemic symptoms or SIRS criteria. And obviously those patients should be admitted. I'm hoping you would admit anybody with tachycardia, fevers, and hypotension. Then what comes up is sort of, what do you need before starting antibiotics? And just blood cultures. So often in ID, we encourage people to hold antibiotics until we can get a tissue diagnosis. Obviously, if somebody's seriously ill, you're not going to wait. So we just request that you get blood cultures first and then start antibiotics. It is still mostly staph and strep species that cause these infections, but gram-negative rods and anaerobes are possible. And so typically we again use Unison plus or minus vancomycin if we think they might have a MRSA history. Or if they've had a lot of recent antibiotics or are immunosuppressed, we use vanc, cefepime, and metronidazole. There are other antibiotic combinations that would work just fine. This is just what we typically do in our guidelines at the VA. And I will say it's not that severe infections are more likely to be gram-negative or drug resistance or polymicrobial. It's just our margin for error is much smaller, and so our empiric coverage is broader because we don't want to have made a mistake. But again, the wound chronicity and the prior exposure to antibiotics is what influences the microbiology, not necessarily the severity of the infection. And people do often ask about Pseudomonas and anaerobes because these are often found in diabetic foot wounds. That said, it is not clear how much of a role they play in the infection, because while Pseudomonas is found in up to 10% of diabetic foot wounds, many of those wounds get better even when they're treated with antibiotics that don't have any activity against Pseudomonas. So again, it's reasonable to cover in patients who've been soaking their feet for whatever reason or have been on prior non-pseudomonal therapy and then they're getting worse. but it's not clear that you absolutely always need to cover for Pseudomonas in diabetic foot infections. We probably don't. And also in terms of anti-anaerobic treatment, again, that is often not necessarily, especially in patients who get surgical debridement of their wound or of any infected bone. So this is just a sort of summary of how we approach our thought to empiric antibiotic coverage when patients presenting with diabetic foot infections. And in terms of duration, if they don't have osteomyelitis, which I will get to in a second, the duration is just a week or two if it's skin and soft tissue only. And obviously oral antibiotics are fine. This is just what people are sort of started on when they're admitted to the hospital. All right, but what about osteomyelitis, which is my area of interest? So going back to this first patient, so coming in, surrounding tissue looks red. When do you think about osteo? So you should think about it when the ulcer is present for more than a month, or if you have the positive probe to bone test. It's worth saying, well, that you can have a probe to bone test that's positive. So like some patients will have a wound going down to the bone. It does not prove that they have osteo. It should just raise your concern. Or if they have an unexplained high sed rate or an abnormal x-ray. So I will say our typical approach is that in anybody with a chronic ulcer, so an ulcer that's been present for more than a month, and certainly if it's a positive probe to bone test, we will get a CBC with diff, an ESR, and get a plain film to do an initial assessment of how concerned we are for osteo. It's worth noting that up to 20% of patients with a mild to moderate diabetic foot infection will have osteomyelitis, and up to 60% of patients with severe diabetic foot infections will have osteomyelitis. So as I mentioned, our workup is typically a radiograph, an ESR and a CBC with diff. The speed of workup, sort of how quickly you need to get on these, depends a little bit on how bad it is, right? Whether superficially it looks like it's a mild, moderate, or severe infection, how quickly it's progressing, and also the patient's ability to follow up, because these can progress in a fairly unpredictable manner. So they can seem okay one week and look quite bad the next week. At the VA, our patients are often followed weekly when there's high concern for infection, or sometimes even twice a week for wound care. And then it's also important to assess like their vascular supply, glycemic control, et cetera. Question about ESR versus CRP. So both the surgeons, all the surgical teams I work with check both. I do not have a strong preference for one over the other. For osteomyelitis, in terms of sensitivity and specificity, both of them are okay, not great. It seems like often the CRP is more dynamic, so certainly will get higher with any sort of early infection. So the CRP sort of goes up first and comes down fairly quickly. And then, whereas the ESR is a slower to respond, slower to get better. I use them both as sort of an extra piece of the puzzle. So if I have if this ESR is high, or the CRP is high, that leads me to be more worried about osteomyelitis. So I'd probably push for an MRI, even if the x-ray looked fine, but it does not prove osteomyelitis. So I use them as sort of something that pushes me to be more or less worried about a patient, but not part of the diagnostic criteria per se. But I often use them both. I don't have a preference for either one, because I think I can make them both mean whatever I want them to mean in a lot of cases. And then another question about isolated osteomyelitis of the toe, a medical problem or a surgical problem. So I will get to that in a minute. The sort of what data is out there about can any of these be treated medically alone? And I will say it's often though a patient preference, right? Like The quickest way to be done with an isolated toe osteomyelitis is to do an amputation of the toe. But there is some data to say that if it's an early infection and there has not been any bony destruction and the patient doesn't have any vascular disease, that you may be able to treat it medically. So getting back to this case, so let's say this is what it looks like on the outside, but the ESR is 125. The X-ray shows this question of periosteal dilation, so you get an MRI and it shows osteomyelitis. So this patient gets admitted, but then the question becomes, again, do you start antibiotics? Do you need to call a surgeon? And if surgery is done, which samples do you send? So getting to that question, antibiotics alone may work for some patients. So this is a study from Spain with 52 patients with mild to moderate diabetic foot infection and evidence of osteomyelitis on X-ray. And they were randomized to either surgical debridement plus 10 days of antibiotics post-surgery or antibiotics alone for being treated for up to 3 months with those antibiotics. And they had no difference in outcome. Worth noting, again, those with severe infection, peripheral arterial disease, Charcot foot, and A1C greater than 10, or chronic kidney disease were all excluded from the study. But they did find that, so for these patients, antibiotics alone of up to 3 months did work. Most, in terms of their antibiotics, most of them were getting like a quinolone plus rifampin. I personally advise a surgical consult, at least for all patients with confirmed osteomyelitis, again, because I feel like the best way to treat most bone infections is with at least some amount of surgical debridement. And if stable, you ideally hold antibiotics until surgical samples are obtained, but that assumes that surgery is going to happen soon. And I also, I mean, in all honesty, a day or two of antibiotics does not actually affect their surgical the tissue cultures all that much. It does make them a little less sensitive, but it's not like it knocks it away to zero. And if we're going to treat surgically, so let's say this patient is going to have a partial ray resection or other surgical debridement, which samples do we send? And what I, as an infectious disease doctor, ask for are cultures of the infected tissue, so I know which antibiotics to use, and then pathology from the proximal resection margin. And I use the culture to determine which antibiotics I need to use, and histology of the proximal resection margin to determine duration of antibiotics. The basic idea being, like, I want to know if all of the infected bone was removed surgically or if there's still infected bone in the patient. And the reason why I prefer histology over culture, so some people will send bone cultures from the margin, those tend to be overly sensitive. So if you think about it, right, like you have the diabetic foot, surgical field open, it is very easy for the bone sample to get sort of contaminated with bacteria from elsewhere in the surgical bed when you're operating on an infected foot. And so this study was 51 patients who had resection of a diabetic foot infection in Basel, and they sent the proximal margins for both histology and culture. And you can see that there were a fair number that had a positive culture, so maybe grew 1 or 2 bacteria on bone culture, but had a negative histology, like under the microscope, that was healthy bone. And this is actually a work we did at the VA, where again, we looked at the proximal margin pathology and then the need for further surgery. Basically, those patients whose proximal margin was positive for osteomyelitis were much more likely to need more surgery than those that had a negative margin for osteo. So we, at the VA, we again use culture to determine which antibiotics we're going to use, and then base our duration post-debridement on the histology from the proximal margin. So if it looks like they do have residual osteomyelitis, they get 6 weeks of therapy. If the margins are clean, they get 0 to 2 weeks of antibiotic therapy after their surgery. Now, what is not clear, I will say, so having a positive margin histologically is clearly bad. What is not clear is whether those prolonged antibiotics actually help, or if those patients are kind of destined to not do very well regardless. And then again, the antibiotics is similar to what we discussed previously, and should be started postoperatively. So again, the typical duration of antibiotics for osteomyelitis is 6 weeks. This is a study from France of 40 patients with mild to moderate diabetic foot infection and osteomyelitis on plain film, so similar to the other. And they were randomized to 6 weeks versus 12 weeks of antibiotics, again, mostly using quinolones plus rifampin. And again, no difference in outcome. And this is, again, these are patients that were treated non-surgically. However, they did not include patients with peripheral artery disease or patients with evidence of bony destruction on the imaging. So basically, if the infection had progressed to the point where it looked like there was destruction of the bone, those patients were excluded from this trial because they were treated surgically. This article came out just in November, looking at 3 versus 6 weeks for osteomyelitis in diabetic foot infections. These were patients that were treated, had some amount of surgical debridement, and then were treated with either 3 or 6 weeks of antibiotic therapy afterwards. And there was no difference in outcome, but it was a pretty small trial. So it's a little bit hard to say whether this proves the answer. Again, I think some of the challenge might be that the patients who are not cured surgically, who also have poorly controlled diabetes or vascular disease or smoking, are at high risk for progression to further surgeries and having ongoing problems. So mild osteomyelitis diagnosed by MRI with antibiotics without deep bone culture. So this often comes up in sort of I always say if it is possible to get a deeper culture, it is preferable. But sometimes the thought is that the biopsy itself or the procedure itself to obtain the culture would be harmful to the patient. And this is when I basically have a discussion with the surgical team about, or potentially with interventional radiology to see if they could do a bone biopsy. If you have, the IDSA guidelines do say to attempt to get a bone sample to guide therapy if at all possible. I think the concern comes up when it's not clear that it's osteomyelitis, when they clearly have a soft tissue infection, but it is not yet clear that the bone is infected. There's understandable reluctance to stick a needle through the soft tissue infection into the bone for concern for causing a bone infection when there wasn't one previously. So I would say that what I typically do in these cases where it's mild, quote unquote, mild osteomyelitis seems pretty early, doesn't seem to have destroyed a ton of bone yet. I will at least try to get, I will get a wound culture to see if there's MRSA in it so that I know whether or not I need to cover MRSA with my antibiotics. And if not, then I feel comfortable going ahead and trying to treat empirically these sort of without any culture data. Sometimes that's just where we are. All right. It is worth noting that our current treatment of osteomyelitis is based on expert opinion from the 1960s. So in this New England Journal article published in 1970, it introduced the idea of bone penetration of antibiotics and set the standard therapy as 4 to 6 weeks of IV antibiotics. They basically said, in our experience, osteomyelitis is not cured without 4 to 6 weeks of IV antibiotics. And that's what we've been doing for the past 50 years. More recently, there was this trial published, the OVIVA trial, published 2 years ago now in the New England Journal, where they looked at oral versus IV antibiotics for bone and joint infections. It was 1,000 patients with orthopedic infections in the UK. And they were randomized to oral or IV antibiotics for the first 6 weeks of therapy. So these were all comers. So spinal infections, diabetic foot infections, prosthetic joint infections, vertebral osteomyelitis, not native joint septic arthritis because they weren't usually treated as long. But basically anybody with an orthopedic infection that would typically have gotten IV antibiotics for 6 weeks was randomized to oral or IV antibiotics. And their outcome was treatment failure at 1 year. So this is just showing that their randomization works. So looking at the percent of patients in IV therapy on the left, the IV group was on IV antibiotics mostly for about 6 weeks. By day 7 of the trial, most people in the oral group were switched over to oral antibiotics. And then on the right is the percent of patients on antibiotics. And you can see there wasn't really a difference in duration between the two groups. And there was no difference in outcome between oral and IV antibiotics. So they looked at their intention to treat population, the per protocol population, all that actually favored oral antibiotics. They then did a worst case sensitivity analysis. So basically they said, okay, what if we assume that every patient that was lost to follow-up did badly if they were on oral and well if they were on IV? And even with that, there was no difference in outcome between the two groups. So this ID doctors have taken this to mean that we can treat bone infections with oral antibiotics. The question always comes up, which oral antibiotics? So in the Oviva trial, ciprofloxacin was actually the most common oral antibiotics, penicillins, clindamycin, doxycycline. The main thing to be in this trial is that in order to be enrolled at all in the trial, an infectious disease physician had to upfront say, okay, if I had to treat this patient with oral antibiotics, I would feel comfortable using this regimen. So they all had to have a good oral option to treat their infection. And by good oral option, I mean one that is absorbed very well by the gut. So quinolones have good oral bioavailability, amoxicillin has good oral bioavailability, as does Clinda, and doxycycline. So those were the ones that were used primarily in that trial. And I will say many of the patients got rifampin in addition to this backbone antibiotic. All right, those were the main things I want to talk about. There's plenty of time for questions. My main sort of closing points that I want to leave you with is that, again, treatment of orthopedic infections typically requires both surgery and antibiotics. Even with aggressive treatment, cure can be elusive or temporary, and that oral antibiotics are likely as effective as IV antibiotics for most patients if chosen and dosed appropriately.